So I had the pleasure of meeting Dr. Campen during my SMI experience in 2011. What I remember most about it was when he was speaking, his family was having a ton of fun on the swing set outside, and that was what I was probably distracted by, and I apologize. And then also, something you'll definitely come away with is his fantastic smile. So please give it up for Dr. John Campen.
Okay, well, thank you very much, and it's a pleasure to be here. When I was asked to speak, I guess they said that I could talk about whatever I wanted to, and I thought I would sort of share our family's story and my story about interest in missions. And I went through medical school in a pretty straightforward way, finished when I was 26, and did my ophthalmology residency right away, finished when I was 30. And I was interested in missions all along. That was part of the reason I went into ophthalmology, because it's one of the sort of easiest ways, sort of the lowest hanging fruit in international health. But I wasn't really quite sure if, what the Lord had for me at that time. And so at that time, I came out to Johns Hopkins. They had a special public health ophthalmology program, and more or less was thinking during that year, it's really better to try to partner with people from other countries. And I was doing some campus ministry, and it was going pretty well. And so I decided, well, why don't I start by being a faculty member? And so I was sort of a lazy faculty member for a couple of years, mostly doing campus ministry. And then I sort of came to the point after we got married in 2000 to be like, well, am I really going to, do the faculty thing or not? And so decided that I would try to follow through with that, and went ahead and got involved in a number of research programs. By God's grace, that's gone pretty well. And I've tried to interact with people internationally throughout this time, and have traveled a lot, mostly to India at first, trying to develop things, but it didn't really seem to get a lot of traction. And as I sort of went along, the campus ministry thing became more and more difficult as I sort of was no longer a student. It was sort of hard to be doing that when I was expected to be seeing a huge panel of patients across campus at the time they were meeting, and so on. And so it seemed like some of that wasn't working out so well. The research was good, and the clinical work was sort of in an underserved area. I'm still the only uveitis practitioner in this whole giant metro area, although there's another one coming in January, fortunately. And so anyway, the research kind of evolved, and that became less of an underserved area. And I was just really thinking, is there a better way that I could sort of more directly harness the skills the Lord has given me to His work? And there's nothing at all wrong with being a faculty member, and one has the opportunity to do things like this, to speak and be encouraging to groups. But it just seemed like there was so much going on that was rather tangentially related to the Lord's work. And also was sort of shutting my family out. We have all these HIPAA regulations and so on, and they really are sort of like not allowed almost to know what I'm doing. And so I was just brainstorming about this, and we were seeking the Lord's will about what to do. And I had been really drawn to really working in international areas is really what is needed, and what people aren't doing that much. And so I went to the International Agency for the Prevention of Blindness meeting in 2008, and it was sort of at that time that it really, I had been thinking in terms, well, maybe we could start a Christian public health school or something, which I think would be a great project. And I guess Indiana Wesleyan maybe is just about to begin one now. But I just thought, well, I'm not really ready to be a dean at this stage, and so I'm not really qualified to do that. And so then I thought, well, I would be qualified to lead something in ophthalmology, and so then I, had admired a work that's led by a non-Christian group in India that has been able to really provide an amazing amount of service and have it be self-sustaining. And so I began to think about yoking that with missions and yoking sort of all the academic background that I've had, which this is now the 16th year that I've been a faculty member. And so the idea kind of came along, well, why don't we try to start a center that's sort of like that one in India in terms of its sort of operational methodology, but is fully yoked with ministry, with having outreach and trying to help build the church. And it really seemed to gel everything that had been brewing for over 40 years at that point. And so we became pretty convinced that was the Lord's will for us to seek to do that. And so we began to think, well, where should we do it? So the first place we thought about doing it was in Indonesia, which would be a fantastic place. But it's actually, you have to go take your boards in Indonesian, which is supposed to be an easy language, but not that easy. And then you have to do a fellowship, under one of the professors there to get a license. I know one person who's working there in some sort of bush hospital, but it's all touch and go every year as to whether he's going to have his license renewed. And there's a lot of jealousy about keeping the foreigners out, even though the ophthalmic situation there is really awful. So we gave up on that and considered many things, went to Egypt. Lori speaks Arabic pretty well, and we had hoped maybe it could be somewhere in the Arab world, because that would be strategic and would make use of her gifts, but we found out that Egypt actually has the most ophthalmologists in the world. And so that didn't seem to be quite the place. And in Egypt, you actually, even if you go to medical school there, they won't give you a medical license, so if you're a foreigner. So we could have gone maybe to Sudan or Yemen was about it, but it wasn't the most stable place to be thinking of building a major facility an ongoing institute, which we were sort of hoping to, jumpstart something that maybe in 10 years or so we could pass on to continue perpetually. So one of my friends, who at the time was the leader of a group called Medical Ministry International, had suggested, well, Ethiopia really is a great place. You should really look into it. And at first I was thinking, well, sub-Saharan Africa, that would be, I was sort of having these grand aspirations. We're going to train people from all over the world. And I'm like, well, he's going to come to sub-Saharan Africa. And over time, I realized, sub-Saharan Africa is actually where the worst problem in the world is and where the most training is needed, And I began to realize, well, Ethiopia is really, maybe is a pretty good place. So we settled on that, I think, at the end of 2009. And since then, we've been kind of keeping this quiet. There are two major research initiatives, or there are more than two now, but at the time there were two major research initiatives, and I was kind of leading or help leading both. And so we were sort of wanting to keep it quiet a little bit until those were done. And even now, I guess I'm not sort of proclaiming it from the rooftop all over my department, although I'm beginning to tell some people, well, I told my chairman a year and a half ago about this, but and I've told Dana Hornbeek, who is like-minded, who's one of our residents. Anyway, we're sort of beginning now to, seek to incorporate and raise support and so on. And so now we're kind of beginning to talk more about this, and these other projects are done. So anyway, I started going to Ethiopia and to sort of the region of Africa. I've discovered over the years I can get myself invited to be a plenary speaker at almost any meeting in the developing world as long as I pay my way to get there. And so in 2009, I went out to Tanzania, where they were having the Ophthalmological Society of Eastern Africa for the first time, and was praying that the Lord would put me together with the perfect partner. And I did meet a fellow named Demisi Tedesi at that time, who was an Ethiopian guy who was working in Kenya, and he had turned around a hospital, and I'm always blanking on the name of the hospital, but it was it was sort of having major troubles and corruption, and in 7 years he had turned it to be the second biggest cataract surgery volume place in Kenya, even though it was in a rural location called Sabatia, so the name has finally come to me. But he was ready to move back to Ethiopia at that time, and so I thought that was interesting. And then later, Scott Lawrence, who used to be the regional director for CMDA in this region, and sort of, I guess, identified too much with us and went to medical school. He had trained in ophthalmology. He was looking to synthesize academic work with missions as well, and so he came with me to the OSEA meeting the next year and decided to join up, and then eventually we came to agree with Dimasi as well to join us. So now we have the three of us trying to take this forward. So that's a little bit of a biographical aspect of where we've been and sort of where we're going. And then I had sort of put this together then into hopefully a certain logic about this to just describe what we had in mind. And in this particular case, one of the things I hope will come out of this will be that it will be a sort of case report, if you will, sort of a demonstration project that something of this nature could be done and might be a good approach to medical missions. So why do we need missions, and ophthalmic missions is sort of what I'm talking about here, but it could be any medical issue. Well, disease of the eye or the body and the soul is a result of original sin, and it's pervasive, and we need deliverance. So we need deliverance at all levels, spiritual being the most important, but also in every way. And Jesus, the second Adam, unlike the first Adam, lived a perfect life and was worthy of God's favor in order to bring redemption to the world, to bring life and healing. And he, as we're mostly, I think, familiar with, offers us this double exchange where he says, well, you can have credit for my life and I'll take credit for your life, and died on the cross to bear the penalty of our sins, but lived a perfect life that we might have the benefit of his righteousness. And when he calls us to follow him, he calls us to participate in his redemptive mission. So there's a place where John the Baptist was saying, well, are you the Messiah or not? And he says, well, tell him, the blind receive sight, the lame walk, and those who have leprosy are cleansed. The deaf hear, the dead are raised, and the good news is proclaimed to the poor. So there are many ways in which you could summarize Jesus' mission, but this is one of the ways he summarized it when he was asked. And so the blind receiving sight is sort of first on the list and was sort of, according to the prophets, one of the signs of the Messiah. And that analogy is very profound spiritually, and it's sort of one of the reasons I went into ophthalmology. His work is done, at least a lot of it is done through using us, so he's in this strange way using imperfect people like us to carry on his work. And since we don't have any power of our own, he empowers us with the Holy Spirit to do these things. And we're to minister in word and deed. And in terms of the deed, our assignment is to reverse the effects of sin in the world, which, one aspect of that is addressing physical disease. And then this provides us with a platform to have a ministry of word. Other people have primarily a ministry of word, and you have this sort of, dichotomy between like your tent makers that have the access but don't have the time, and the preachers who have the time but not the access to carry out the ministry, although I guess one might argue whether they really have time either. So anyway, medicine provides us a very practical tool to serve one's fellow man. And in ophthalmology in particular, you have this image of restoring sight to the blind, which is sort of a sign of the gospel, basically making us to see again. And it was characteristic of Jesus' own ministry that he both proclaimed the gospel and healed. So he preached and he healed. And there's a nice book called Preach and Heal, which I would encourage you to consider reading if you haven't seen that. And that the blind were receiving their sight was evidence that the kingdom was at hand and heralded the king, like we said, and it can be that way today too. Now, missiology focuses on the scriptural concept that Christ followers are to go throughout the earth bringing the message of Christ, of hope and redemption, and to enculturate it into self-perpetuating, growing indigenous churches. And so that's sort of what church planting is about. And that's sort of Jesus' mission, is to spread his church all over the world. So maybe those of us who are blessed with the skill to reverse or prevent blindness or other diseases are called to go throughout the world and enculturate something like that to overcome the effects of sin, in this case manifested by eye disease, and use it as a tool to further Jesus' church planting mission. And church planting mentions it's sensible to go where the church doesn't exist, or where it needs a lot of outside input to get it out of the doldrums, which is maybe something like what we're talking about this week and focusing on Europe. But otherwise, people that are culturally on the inside would be the most efficient gospel ministers. So we should seek to raise up, people that are from the culture that can carry on ministry the most effective. And this, I think, applies to some extent in healthcare as well as in church planting. Now, with healthcare types of things, it's not always exactly the same. So some places that are very needy have had wonderful movements of the Spirit in their country, and many of them are Christian, and we're increasingly seeing that the Southern Hemisphere is sort of where a lot of the action is and where a lot of the missionaries are beginning to come from. But, and it's not necessarily wrong, I don't think, to work in those areas, and some might say Ethiopia is one of them, but the ideal scenario is one where both are needed. So let's talk about some of the technical aspects. So there are about 161 million people worldwide with low vision and about 40 million who are blind, according to fairly recent, rather crude estimates. And the region with the highest burden of blindness is sub-Saharan Africa. And developing countries have something like 5 times as much blindness than we do here in the United States, basically because services aren't available, to most people. And so especially cataracts, which cause like half of blindness, are not operated for the most part. So I think I sort of discussed that already. All right, so if we were going to try to go overseas and we wanted to work in an area of need, how would we approach it? And so there's this common analogy about fishing, about giving people food. So, the quote is, give a man a fish and you feed him for a day, teach a man to fish and you feed him for a lifetime. And so, what if the region's overfished? Well, then you can, stock the pond. What if they need better technology? Well, you can improve fishing technology. So there are all kinds of things you can do with this analogy. So what would it look like in terms of blindness alleviation? So giving somebody a fish is sort of like, just going there and fixing things. And there are many people that are going on short-term trips and doing surgery and fixing a few eyes, and there are strategic roles for that. But then once you're gone, then it's over, and it's only a small impact. So teaching him to fish then is sort of the other part of the analogy. So this would be like providing high quality training and mentoring and discipleship. In making the food abundant, this would be something like high quality public health programs and identifying those needing help and putting in interventions to prevent blindness. We'll talk in a minute how there are some public health kind of diseases that are causing blindness in the world. You can improve fishing technology through research, learning to do things better, or else to do it sort of in an appropriate technology kind of way, which has been done some in ophthalmology, and then teach them to teach and reproduce themselves. So that's getting into leadership and institutional development. Why sort of, I'm using the word high quality here, so why, high quality? To some extent there's a trade-off between quality and volume, and we talk about this at Esperanza, where the quality is sort of, way up high and the volume is not as high. And the Lord commands us to love your neighbor as yourself. So, would you want quality if you were getting services? And then if you think it through, only high quality work will stand, So if you're doing poor work, you actually, give, say, cataract surgery a bad reputation. There are a lot of assessments, population-based assessments, where they go out and look at the causes of blindness in developing countries. And so the number one is always cataract. But sometimes the number 2 one is bad cataract surgery. And so if you start doing that, you're never going to get the population to take up cataract surgery if everybody knows somebody who's blind because of bad surgery. So the world is replete with programs that are going nowhere because quality is poor, and the sustainability model depends on willingness to pay. And so if people are not willing to pay for services because everyone knows the quality is poor, then you're not going to go anywhere. So if you have good quality services and you're able to make it available at a reasonable price, then you can really multiply and explode in volume. And the poor are actually the most discriminating investors. If you ask a poor person to pay a month's wages, it's not very much money, but it's like all they have. And they don't have the kind of surplus. We were just reading to the children last night about the widow's mite, and why that was more, than all of the wealthy people that were giving to the temple. What about the sort of applicability of this then to Jesus' church planting mission? So when you start providing services that restore sight to the blind, many people will flock to hear that. So that provides a lot of time and also sort of an openness to listen to why people are doing this. So this allows for direct spiritual outreach. One can arrange outreaches in conjunction with churches or missionaries or indigenous partners and sort of give them the credit, for bringing this to pass. And so this provides a lot of opportunity to help churches with their ministry and help pioneers and others to sort of get a foothold in the place. And it provides a welcome over spiritual and cultural barriers. So if you're trying to work in, say, an Islamic area that is sort of not usually very receptive to Christians coming in, if you're providing blindness alleviation or healthcare, then you tend to be much more welcome. And people also will flock to training opportunities. And so in the setting of doing all of this, by mentoring people sort of at all levels, not just at the highest level, this can provide a lot of opportunities. And so we envision doing that, and in particular, there's been a lot of trouble in Ethiopia with sort of the status of women getting married off at a very early age. Some of you might have read about the fistula hospital there and the problems that have led to that problem. And so we're quite interested in finding young women and sort of training them to do some of the sort of paramedical kinds of tasks for this. All right, so there are 4 basic domains of things that one might do in an academic center. And so one is providing clinical care. And this is a sort of pie chart of the causes of vision loss. Since I am a specialist in one of the areas that doesn't get counted, I always look at the other as being a very big one. And you can see that there are a lot of very small ones that are counted because they've been traditionally part of the focus of international ophthalmology. But you can see that, cataract is half, glaucoma is, a big chunk, and macular degeneration is mostly a European problem, but that's a big chunk, and diabetic retinopathy. All these things require clinical care to address, whereas in the past, it used to be much more sort of public health oriented diseases. I'm sorry, this is kind of blurry. So, at least a quarter requires clinical care, and, maybe some of these do too. And so a lot of blindness alleviation is going to require clinical care. So we have to provide clinical care and train and retain clinicians focusing on what needs to be done. And our view is that we should focus on ophthalmologists. There's a movement towards trying to train technicians to do cataract surgery in Africa. And this is sort of argued that, you'll never train enough people. But then, one also notices that a lot of these technicians end up in labor and delivery a few months after finishing their training. and it does take a while to train them, and it sort of, in my mind, sort of eviscerates the field if you say, well, there's no subspecialty training available in this field, but we're going to have technicians do sort of the main surgery in the field. And so we think that it's better to focus on raising up ophthalmologists, and this is how it's been done in India, which is the main paradigm, and also Nepal, the main paradigms of success in raising up systems like what we're trying to do on the technical side. So ophthalmologists have a lot of advantages. They're fully trained, so if something goes wrong, they're better able to address it, internationally recognized credentials, and are always going to be required for the more complicated problems that you'll end up having to deal with once you start dealing with the more common ones. So training then requires high quality training, such as many of you are in the process of doing here, and retention requires a perception that it's a rewarding career. So this is a big problem in Eastern Africa, that ophthalmology is not viewed as a rewarding career, and part of it is the reason I just said, and part of it is, I think when we say we can do things cost effectively, it's sort of perceived then as being cheap, and that people aren't able to sort of make a good living at it. So there should be a modeling of successful rewarding careers, but it should still preserve attention to the poor. And so that's difficult to do, because it's sort of much more attractive to just skim the cream off the milk, and get fat. But as Christ followers, then we have a prominent role to play in preserving attention to the poor and modeling that, and training our followers to do that as well. There is public health work that an institution such as we aspire to do can put in place. So there are diseases like trachoma and onchocerciasis, especially trachoma in Ethiopia is a huge problem. And then practical approaches are needed to diabetes management, preventing diabetic retinopathy, bringing cataract and refractive services together, and identifying other opportunities. Like, still even in the West, nobody's really figured out a viable public health strategy to deal with glaucoma, which is a huge problem in Africa. Research has a big role. It, in my experience, causes an institution to thrive, having research, and so there's that aspect. And then there are a lot of problems going on in developing countries that sort of need to be addressed in the developing country context, which has not really been done. And programmatic research about how to do these things effectively is particularly important, and there are some WHO-endorsed priorities that have been done. So how would we accomplish these things? So in India, has pioneered this sort of model that you have, different levels. So you have a center of excellence. You have sort of centers below that have some subspecialty services. You have centers below that do the sort of bread and butter, like cataract surgery, and vision centers below that are like an optical shop in the community that people get glasses, and then people that are sort of like public health workers in the remote areas that would sort of look out for people that need eye help. So this is always presented as a pyramid, and it's one good model. So one of the things that has always struck me is that this pyramid is upside down here. It's really like this. So, because everything all the way to the base of the pyramid is contingent on having that center of excellence at the top. And that's always, in the places that have succeeded, have been the places that people have started. And so it's really here then that everything else flows from. And so starting this is sort of what we're aspiring to do. It provides us, I think of it as an analogy to from your chemistry, when there's a liquid freezing, it freezes by having little spots where the freezing starts, points of nucleation, and then it rapidly spreads from there. So I think that having sort of a tertiary center or center of excellence, that we need to have lots of those all over the place. It provides the ideal opportunity for training and encouraging ophthalmologists and ophthalmic public health workers and mid-level professionals. It's a visible presence for fundraising and government engagement, and a good base for doing research, and it can be self-sustaining, and spiritual things can be incorporated into all of these levels. So I mentioned before, when we were looking around for where we wanted to work, we thought of sub-Saharan Africa. So just to give you some of the basis for that, most countries have about one ophthalmologist per million, and what was it in the US, Lori? It was something like 100 times as many ophthalmologists.
250 times. There's like 25,000 ophthalmologists in the United States and about 103.
Yeah.
And there's 7-point-some million visually impaired people in the United States and 4.6. Is that
Yeah.
right?
Okay, so there's
In Ethiopia.
more than 100 times the density of ophthalmologists in the US, probably much more than that in Philadelphia, which is the site of the US's first medical school and the US's first eye hospital. And in a lot of Africa's services are interrupted by political strife, so Ethiopia is not one of those places, fortunately. And there's a lot of sense of discouragement among ophthalmologists, a sense that ophthalmology is not as prestigious as OB-GYN or sort of working in an AIDS program that's being well funded by the Gates Foundation or something. And so there's been limited progress towards blindness alleviation and few, if any, true tertiary centers in Africa. And so some people have actually argued it won't work in Africa, no way it's going to work. And so this has sort of been fighting words, from my perspective, to see if we could give it a try to make that happen. So when we were thinking through where to put it and eventually settled on Ethiopia, we were thinking about where is politically stable. So, this region of Africa is extremely unstable in general, but Ethiopia is an island of stability in the midst of it. It should be a large population if you're going to have a large center and have all kinds of subspecialty services eventually, and there should be a high level of need, meaning a high level of visually impaired people and a low level of existing services. And it should be a large city with high visibility, good transportation, and a place that people would be willing to come from all over Africa to be trained. So Addis Ababa seemed to meet that need. And the church has been said to provide between like 40 and 75% of all healthcare in sub-Saharan Africa. The traditional mission hospital model has been criticized because of sustainability issues, such as when the founder dies or has to retire, or just when prices start getting too high because medical care is expensive. And ophthalmology is a little bit easier than some areas because you don't really need a proper hospital, and you're basically really have a hostel, not a hospital. So we thought through how can we provide sustainable services and do it in Jesus' name. So we thought about this model I've been describing and incorporating the spiritual aspect. And so we're basically trying to marry, I guess, then the best methods for the technical side with the preservation of attention to outreach, and to try to do everything in Jesus' name. The work of Christ in the hearts of women and men motivates more people to serve the poor than any other motivation in the world, and so the church is very well placed to meet these needs in healthcare, as we see all over the world. And I think we should seek to bless and cooperate with those who are doing the same thing for different reasons, such as the group in India that we are emulating on the technical side. But as Christ followers, we need to step up to the plate to deal with these problems and develop self-sustaining, high-quality institutions. So again, this was part of our thinking in wanting to carry out this kind of role. Christ followers provide the world's largest pool of goers and senders who can address these needs, and the motivation to serve rather than be served is foundational to both initiating and maintaining an institution that will serve the poor. So we need to sort of enculturate that into the institutions that we start. And one of the things Lori and I thought about is, like I have sort of a prestigious position here in the United States, but my children don't really know about it, and in a way the prestige is kind of almost corrupting, like if they're trying to seek it just, because of that, it's not really a good motivation for them. Whereas if they see us sort of really doing something for the Lord, it's really, I think, a blessing to them, and one of the things we would like to, the examples we'd like to give them, similar to the example that Lori's parents gave to her. So in trying to develop an institution like this, then we should apply the best practices that the world has to offer in ophthalmic missions. We shouldn't secularize ourselves, however, but we should be fully spiritually motivated in the things that we're doing. So we should take sort of the best from the secular world, but we shouldn't give up the spiritual motivation, which is our lifeline. And an institution that's centered on Christ offers a number of advantages and partnerships, perpetuation of his work, and although it's not the only possible way of service, it's a good way in terms of providing ongoing attention to the poor, as well as the sort of missional opportunities that it provides. So then my proposed academic model, if you will, is that we should synthesize the best practices in the world with the power of the Holy Spirit to address the issues that prevail in ophthalmology, or it could be some other form of healthcare. And we should go forth and do it in Jesus' name, testifying to him in word and deed. And the deeds provide a foundation for sharing the word to those who are open. Because the training and research are central to the institutional establishment, it could be called academic, but because the motivation is to bring healing in Jesus' name and to use it as a practical tool to build the church, it's missions. So just a little bit about Ethiopia. It's the second largest population in Africa. Probably most people are saying 90 million now. It's quite a bit more in Nigeria, which is the number one, and it's not much less in Egypt, but that's really part of the Middle East. It's politically stable. It has pretty limited governmental and non-governmental services available. The cataract surgery rate is less than 1/6 of what's needed. They just started a third residency program, but they have a problem that each state sort of picks what they want people to be trained in, and you can't sort of pay your own way to go to training. So you can't be trained unless somebody chooses you. It's sort of like everyone has to be trained through ROTC or something like that. And if the ROTC people don't pick ophthalmology, then nobody gets trained in ophthalmology. So there's a big, these programs are not full for that reason. The blindness prevalence is 1.6% for all ages, so it's one of the highest in the world. Most blind people would be over 50, which is only, I think, 12% of Ethiopia's population. And it's furthermore the epicenter of one of the main sort of public health eye diseases, trachoma. So there are over 1 million cataract surgery backlog, maybe more like 2 million, and over 1 million trachoma surgery backlog, which surely is like double the next biggest country in the world. Cataract and glaucoma are big problems. This is just an example of cataract, and a simple surgery can fix this more or less permanently. Glaucoma is a bigger problem. We're able to treat that, but it requires ongoing input and is still working on sort of a viable model for that. Trachoma is an infectious disease that leads to something that almost looks like an autoimmune process. Since I'm sort of into immunity, everything, it's like everything looks like a nail to a hammer, right? But anyway, they get this chronic cicatrization, and then this sort of, tightens the inner lamella of the lid, leading the lashes to rotate inward and scratch on the cornea, leading to corneal opacities. And it also sort of just destroys the lubricability of the ocular surface, and so it leads to blindness that way. And the blindness is not really treatable. It's mostly a prevention thing, and it's rotating the eyelid to get these lashes off the cornea is one of the big things. So Ethiopia then is a good place, just to make the argument as to why it was a good place for us. It has good access. It has the most connected airline in Africa, where you can get your Star Alliance points. And it has this sort of juxtaposition of wealth, and poverty right next to each other. And this is a big apartment building immediately next to this informal housing, and sort of vast areas. You can't see this very well, but this is just a whole mountain covered by informal housing. And so there's vast amounts of poverty, but there's some middle class and upper class, so there's a potential to cross-subsidize. We are looking at using a model sort of borrowed from India and Nepal, where in essence it's like the airlines or maybe a train, where you have several classes and people voluntarily choose to pay more if they have more because it's more comfortable. And then the people that are riding coach can ride much cheaper. So it's not quite as good as the airplanes aren't quite as good of an example because there are only two classes really, but on the trains there are many classes, but the whole train is going from the same place to the same place. And so if you provide everybody with the same level of services, but it's sort of a little bit more comfortable or more prestigious, for some, then they may pay many times as much and subsidize many other people. And so this provides a situation where that can happen. there are a number of capable ophthalmologists and many trainees. Like, people are always wanting to do a fellowship with me when I go there. And private practice has just begun to proliferate. There are 2 private practices there now. The government institutions have permitted their staff to use the public facilities for private practice after hours, so there's some movement towards a more financially rewarding career for people. And we have this problem I mentioned about the bureaucracy determining who gets trained. So if we can open a training program and let anyone come who wants to, especially people that might carry forward our vision in the years afterwards, then there should be a lot of demand for that. So in a way, the barriers that exist there provide opportunities. In terms of the missional importance, this is sort of showing that Ethiopia has been the front between Islam and the rest of Africa for over 1,000 years. So they held off the Islamic forces at the time of the Islamic Empire. And I guess the Islamic forces were very good at fighting in the desert, and Ethiopia has highlands in the middle there, and they weren't able to conquer it. And even now you can see, the green is Islam, and the bluish purple is strongly Christian. So there's a little island of Orthodox Christianity there in Ethiopia, and then mixed Islam and Christianity here. So this is sort of a front, in the battle, sort of the spiritual battle over Africa in this place. So there are, a number of Christians there, and really the Orthodox Christians have been in power all this time. But there are good opportunities for reaching Muslims, and this is also seen as a good area for Islamic evangelization as well, and lots of money pouring in there. Ethiopia they have many people groups in like 80 different languages, but there's sort of a history of getting along relatively well. I mean, there have been problems, but, and it's sort of a little bit easier than to talk to Muslims and for Muslims to talk to Christians as well. And also they've tended to be a little bit more Sufi rather than radical. And so there's a number actually of fruitful Islamic outreaches going on, some of whom want to partner with us. So the blindness problem then provides a good opportunity to go into some of these places where there are unreached Muslim or even animist people groups, and then mostly unreached groups, and partner with some of these people that are doing these kinds of ministries there. So it's sort of missionally strategic, even though there are a lot of Christians in the country. So we're planning to organize this in Ethiopia with a private not-for-profit kind of setup, but we really want to, it's not possible to be not-for-profit and private there, and it's not possible to be a charity because of their regulations. So we're trying to work it out so that it's owned by a nonprofit in the United States to try to work around that, which has been a lot of complexity. We're looking to jumpstart it with people like myself and Dr. Lawrence to get things going, and then hopefully over the years raise up many Ethiopians that can be great leaders. And they do have a culture. It's the only country that wasn't taken by Europe other than for a 4-year period during World War II, and actually the only country to defeat European invaders successfully. So they have kind of a lot of status because of that. And also they have this sort of long history going way back before Christ, whereas in a lot of Africa the history is just not known. And so there's sort of a cultural strength, and a lot of smart people. And so I think it has a lot of promise to do that. We're looking to have the gospel ministry be intrinsic at all levels, like I was said, and to maintain focus on the poor using a cross-subsidization technique to make extremely inexpensive or free surgery available to the people who need that level of services, and to have the better off people still choose to come to our place and cross-subsidize them voluntarily rather than sort of by forcing them to pay more. And we'll have an interdenominational Christian identity and partner with seminaries and missionaries and churches, and we have some people that are interested in doing that now. And I think I'm late, so why don't I go ahead and stop at that point. I'll just show a few other pictures. These are just showing, some of the opportunities there will be to minister to all of these people while they're waiting. This was an outreach that Jeff Taven was doing the time when Lori came with me. And so the line was like this, like this, like this, out the door, and sort of way down the street. Just hundreds of people sitting all day in line. And then they might stay in the hospital afterwards, maybe have a private room if you choose to pay more, and cross-subsidize all these poor people on the ward. And so there's a lot of opportunity to reach out to them, in a sensitive way, doing something like the saline solution, where you sort of see if someone has spiritual interest and then follow up on that, but don't kind of blast them if they don't have any interest, because that's sort of vain and counterproductive. It has both need for services in the urban setting and in the rural setting, and this can be accomplished by doing outreach camps, is what they call it in India, where you would go basically screen people, identify people that need cataract surgery, put them on a bus and send them to the base hospital and do the trachoma surgery and the glasses on the spot, and then just suggest referral to the other cases. So focusing on the primary things. And we're trying to do this maintaining our university appointments. And so my chairman is favorable about this. I have to work out a way that it's not going to be a big financial liability to the university, but since the University of Pennsylvania is private and interested in one of the Penn Compact 2020, one of the main goals is to increase its notoriety globally. It's a pretty famous place globally, but everywhere I go, people think I'm from Wills. And if I say I'm from Philadelphia, and so they have, a ways to go. And so developing an international program is in the university's interest. And so I'm sort of trying to walk the line where I want to use their status and the interest of my colleagues in coming over for a couple of weeks a year to help out without giving the university the control over this. And the university wouldn't want the control because it's a risk, it's a financial liability if it crumbled. And so that seems to be working out, and we're hoping to raise support like a missionary through the US 501c3 we're starting Sight for Souls, and then push the money through the university, and then maybe I'll be getting some grants, or else maybe I'll just have a lower salary. We aim to bring some grants and collaborations along with us, like I have several grants presently, including one to do a research project in Ethiopia and maintaining editorial board positions. So I seem to have attracted a lot of editorial board positions. And so hopefully that can help to provide status to the institution. And why don't I just, let me just go over the problems. What our problems are: to provide more partners. So now we have a glaucoma specialist, a uveitis specialist, and a high volume cataract surgeon as our startup team, but we really could use a retina specialist. There may be an Ethiopian one that will be joining us, but we'll see. There's some worry that the people starting those two private practices will view us as competitors if the Ferengi doctor is there and drawing all of the diplomats, because Addis Ababa is the #2 city supposedly in terms of the number of diplomats in the world. But so far they seem to be very favorable. Only one of them knows that we're actually planning to come there, but he was very favorable. I've been trying to train everyone in advance of deployment and being a plenary speaker at all of their conferences, like I've said, and so that's been helpful. My specialty actually is not available at all in sub-Saharan Africa, even in South Africa, although there are some people that are not formally trained that are doing it in South Africa. And so hopefully that would be, I probably will end up with a clinic of sort of like seeing the patients where the people don't know what's going on. And hopefully they'll view that as a plus rather than a minus. We'll integrate the Ethiopian participants. We'll try to help the other people as well, not compete with them too much, because there's an abundance of material, and there seems to be great understanding of that in Ethiopia, that everybody just thinks, yeah, we're not even doing 1/10 what we need to do, and we want more people, so everyone's been very positive. We have a lot of regulatory issues that we're trying to overcome, like I described, and that we need to raise support. We have one potential large supporter, but I just really wonder if that's going to happen or not. So we're seeking grants and supporters in advance.